Welcome to Pediatric Case Review, Musculoskeletal Series. Today's lecture is a comprehensive case-based clinical review of Sever's disease, also known as calcaneal apophysitis. This is the most common cause of heel pain in physically active children and adolescents. We will work through 16 evidence-based clinical cases covering the diagnosis, clinical presentation, examination findings, pathophysiology, diagnostic workup, treatment strategies, rehabilitation, and associated conditions. Let us begin. Case 1. A 12-year-old male competitive soccer player presents with a chief complaint of heel pain. History: gradual onset of posterior heel pain over the past 4 weeks. Pain worsens significantly during running and jumping. Noticeably increased training intensity at the start of the season. No history of direct trauma or injury. Pain improves with rest overnight, and his mother reports he now limps after training sessions. Examination: tenderness localized to the posterior heel. No erythema, warmth, or swelling. Mild antalgic gait observed. No systemic symptoms. Afebrile and well-appearing. What is the most likely diagnosis? Option A: plantar fasciitis. Option B: Achilles tendonitis. Option C: Osgood-Schlatter disease. Option D: Sever's disease. The correct answer is Option D: Sever's disease, also called calcaneal apophysitis. Sever's disease is the most common cause of heel pain in physically active children aged 8 to 15 years. It results from repetitive traction on the calcaneal apophysis, which is the growth plate at the heel, during periods of rapid skeletal growth. The age group is 8 to 15 years with a peak at 11 to 13 years. The trigger is a rapid growth spurt combined with increased physical activity, and the location is the posterior heel, which is bilateral in approximately 60% of cases. The Achilles tendon pulls repeatedly on the immature calcaneal growth plate, generating microtrauma and inflammation. Case 2. A 10-year-old female competitive gymnast presents with a 4-week history of pain in both heels. The pain worsens during training sessions and floor exercises. She denies any history of trauma or falls. Her mother notes she has recently entered a period of rapid growth and has significantly increased her training hours. What percentage of Sever's disease cases present bilaterally? Option A: 10%. Option B: 60%. Option C: 90%. Option D: 5%. The correct answer is Option B. Up to 60% of Sever's disease cases present bilaterally. Both calcaneal apophyses undergo the same growth plate vulnerability during adolescent growth spurts, making bilateral involvement physiologically expected. Sports such as soccer, basketball, and gymnastics load both heels simultaneously, creating equal traction stress on both sides. An important clinical pearl: pain may begin unilaterally but progress bilaterally. So always examine both heels even when only one is symptomatic. The condition is more common in boys, with a peak age of 11 to 13 years. Case 3. An 11-year-old boy presents with right heel pain that started 4 weeks ago after joining his school basketball team. He describes the pain as a dull ache that becomes sharp during running, jumping, and pivoting, and is worse during and immediately after practice sessions. On examination, there is no swelling, no redness, and no warmth over the heel. He is afebrile. The pain completely resolves after a night's rest, but returns promptly once he resumes physical activity the following day. Which of the following features is most characteristic of Sever's disease in this child? Option A: activity-related pain worsening during and after exercise. Option B: morning stiffness lasting more than 30 minutes. Option C: persistent pain at night interfering with sleep. Option D: constant pain at rest unrelated to physical activity. The correct answer is Option A: activity-related pain worsening during and after exercise. Pain in Sever's disease is mechanical and activity-driven, triggered by repetitive impact loading on the inflamed calcaneal apophysis. Rest reliably reduces symptoms because it removes the traction stress on the growth plate. This is the hallmark pain pattern: minimal discomfort at rest, mild pain with light activity, and peak discomfort during running and jumping. Night pain or pain at rest should raise suspicion for alternative diagnoses such as osteomyelitis or bone tumor, and warrants further investigation, including magnetic resonance imaging and inflammatory markers. Case 4. An 11-year-old male basketball player presents with right heel pain that began shortly after starting a new basketball season 3 weeks ago. On observation, he avoids placing his right heel on the ground while walking. His mother reports he has been increasingly irritable due to persistent discomfort after practice. There is no history of trauma, fever, or systemic illness. No swelling or redness over the heel. Pain is localized to the posterior heel and worsens with activity. What is the most common gait adaptation seen in children with this condition? Option A, Trendelenburg gait. Option B, scissor gait. Option C, toe walking. Option D, antalgic limp. The correct answer is option C, toe walking to reduce heel pressure. Toe walking, also called tiptoe gait, is a classic protective adaptation in Sever's disease. By rising onto the forefoot, the child reduces ground impact on the inflamed calcaneal apophysis, effectively offloading the painful heel. This is a pain avoidance behavior, not a neurological finding, and it resolves as the condition improves. The clinical pearl is toe walking in an active child aged 8 to 15 with no neurological signs should prompt evaluation for calcaneal apophysitis. Case 5. A 12-year-old male soccer player presents with right heel pain for 3 weeks. Pain worsens during training and improves with rest. On examination, the physician applies firm compression to the medial and lateral aspects of the posterior heel simultaneously. The child winces and reports sharp, localized pain at the posterior heel. What is the name of this clinical examination maneuver? Option A, Thompson test. Option B, positive calcaneal squeeze test. Option C, Silferskield test. Option D, Phelan test. The correct answer is option B, the positive calcaneal squeeze test. The squeeze test is performed by applying medial and lateral compression of the posterior heel simultaneously with the examiner's hand. A positive finding is reproduction of pain at the calcaneal apophysis upon compression, which confirms the diagnosis of Sever's disease. The growth plate lies between the medial and lateral walls of the posterior calcaneus, and direct compression irritates the inflamed apophysis, producing sharp localized pain. The squeeze test is the most reliable clinical maneuver for diagnosing calcaneal apophysitis and is more specific than palpation alone. Case 6. A 13-year-old boy who plays competitive football presents with right heel pain lasting for weeks. During physical examination, the physician attempts to bend the foot upward toward the shin. The patient reports pain and resistance at the posterior heel, and the movement is notably limited compared to the other side. What does this examination finding most likely indicate? Option A, ligamentous laxity. Option B, hyperflexibility. Option C, joint effusion. Option D, limited ankle dorsiflexion. The correct answer is option D, limited ankle dorsiflexion. Limited ankle dorsiflexion is the hallmark sign of triceps shurai tightness in Sever's disease. During rapid growth spurts, the gastrocnemius and soleus muscles fail to lengthen at the same rate as the growing calcaneus. This creates persistent tension along the Achilles tendon, generating excessive traction force on the calcaneal apophysis. In Sever's disease, a normal dorsiflexion range of 10 to 20 degrees is reduced to less than 10 degrees. Use the Silferskield test to differentiate isolated gastrocnemius tightness from combined gastrocnemius and soleus tightness. Case 7. A 9-year-old boy is brought to the clinic with a 3-week history of right heel pain. He is an avid football player and has been training daily. The pain worsens after practice and improves with overnight rest. He has no fever, no swelling, and no redness. On physical examination, the physician begins systematic palpation of the heel and surrounding structures. The child is most tender at one specific anatomical location, and the pain is sharply reproduced upon direct palpation of this site. Where is the maximal point of tenderness most likely located in this child? Option A, posterior calcaneal apophysis. Option B, plantar fascia origin. Option C, mid-substance Achilles tendon. Option D, medial malleolus. The correct answer is option A, the posterior calcaneal apophysis. The calcaneal apophysis is the secondary ossification center at the posterior heel, serving as the Achilles tendon insertion point. During growth spurts, this cartilaginous plate is softer than adjacent tendons, making it the first to fail under traction stress. Tenderness is focal and specifically localized to the posterolateral heel, directly over the apophysis, not the tendon itself and not the plantar fascia. The clinical pearl, tenderness at the mid-tendon suggests Achilles tendinopathy. Tenderness at the plantar heel suggests plantar fasciitis, and posterior heel tenderness in a child means think apophysitis first. Case 8. A 12-year-old male soccer player presents with posterior heel pain that worsens during practice. On examination, the physician notes point tenderness localized to the posterior heel. There is no visible swelling, redness, or warmth. The pain does not involve the mid-portion of the Achilles tendon. His symptoms began gradually after starting the new season. Which of the following findings best distinguishes Sever's disease from Achilles tendonitis? Option A, pain is located at the ankle joint line. Option B, swelling is diffuse and involves the entire hindfoot. Option C, Tenderness is localized to the calcaneal apophysis, not the tendon midsubstance. Option D. Fever and systemic symptoms are present. The correct answer is option C. Tenderness localized to the calcaneal apophysis rather than the Achilles tendon insertion. The location of maximum tenderness is the key principle that distinguishes Sever's disease from Achilles tendinitis. In calcaneal apophysitis, pain is felt directly over the growth plate at the posterior inferior heel, while Achilles pathology causes pain at the tendon insertion at the posterior superior heel. Palpate systematically. Apophysis tenderness indicates growth plate irritation, while tendon insertion tenderness suggests primary tendon pathology. Sever's disease affects ages 8 to 15. Achilles tendinitis can occur at any age and involves tendon thickening and morning stiffness. Case 9. A 13-year-old boy presents with a 4-week history of right heel pain. He recently joined a school football team and has significantly increased his running and jumping activities. He is currently in a rapid growth phase, with his parents noting he has grown 8 centimeters in the past year. There is no history of trauma, fever, or systemic illness. On examination, tenderness is localized to the posterior heel and the squeeze test is positive. What is the underlying pathophysiology responsible for this condition? Option A. Autoimmune inflammation of the synovial membrane. Option B. Traction apophysitis due to repetitive mechanical stress on the calcaneal growth plate. Option C. Bacterial infection of the calcaneal bone. Option D. Ischemic necrosis of the calcaneal epiphysis. The correct answer is option B. Traction apophysitis due to repetitive mechanical stress on the immature calcaneal growth plate. The calcaneal apophysis is cartilaginous and unfused in children aged 8 to 15, making it the weakest point in the Achilles calcaneus complex. During running and jumping, the Achilles tendon repeatedly pulls on this vulnerable growth plate, generating microtrauma with each impact. During growth spurts, the calcaneus elongates faster than the calf muscles can adapt, increasing tension on the apophysis and amplifying traction forces. Ground reaction forces during running can reach up to 880 kilopascals in affected children, over 10 times higher than during normal walking. This is why symptoms are always activity-related. Case 10. A 13-year-old basketball player presents with bilateral heel pain that developed over the past 2 months. His mother reports he has grown 4 inches in the last year and frequently complains of tight calf muscles. Physical examination reveals limited ankle dorsiflexion and a positive squeeze test bilaterally. Which factor best explains why Sever's disease commonly occurs during adolescent growth spurts? Option A. Decreased physical activity levels during adolescence. Option B. Rapid bone growth outpacing muscle and tendon lengthening. Option C. Vitamin D deficiency commonly seen in teenagers. Option D. Increased bone density causing mechanical stress. The correct answer is option B. Rapid bone growth outpacing muscle and tendon lengthening. During a growth spurt, the calcaneus elongates rapidly, but the gastrocnemius and soleus muscles cannot lengthen at the same pace. This creates a functionally tight triceps surae complex, pulling the Achilles tendon with increasing force against the still cartilaginous calcaneal apophysis. The result is repetitive microtrauma, inflammation, and calcaneal apophysitis. The growth plate is the weakest link, not the tendon and not the bone. It absorbs the excess strain. An important clinical pearl: Sever's disease resolves spontaneously once the calcaneal apophysis fully ossifies, typically by ages 13 to 15 in girls and 15 to 17 in boys. Case 11. A 13-year-old male athlete presents with a 6-week history of progressive right heel pain, worsening with running and jumping. He recently started competitive soccer training. He denies any trauma, fever, or systemic symptoms. On examination, there is localized tenderness at the posterior heel with a positive calcaneal squeeze test. Plain X-rays of the right foot are obtained and reveal increased density and irregular contour of the calcaneal apophysis, with apparent fragmentation at the posterior heel. Which of the following best describes these radiographic findings? Option A. Sclerosis and fragmentation of the calcaneal apophysis. Option B. Malignant bone tumor involving the calcaneus. Option C. Acute fracture line through the calcaneal body. Option D. Normal radiographic appearance in a growing child. The correct answer is option A. Sclerosis and fragmentation of the calcaneal apophysis. Sclerosis, meaning increased bone density, and fragmentation of the calcaneal apophysis are the classic radiographic findings in Sever's disease. The apophysis may appear irregular, dense, or multifragmented. However, an important caveat: these changes are also seen in asymptomatic children as a normal developmental variant. Therefore, X-ray alone cannot confirm Sever's disease, and the diagnosis remains primarily clinical. Diagnosis requires posterior heel pain plus activity-related onset, plus a positive squeeze test, plus appropriate age between 8 and 15 years. X-ray serves to rule out stress fractures, osteomyelitis, or tarsal coalition. Always obtain bilateral X-rays for comparison. Case 12. An 11-year-old girl presents with persistent left heel pain that has failed to improve after 6 weeks of conservative treatment, including rest, ice, and heel cups. She remains active in gymnastics and reports pain both during and after training sessions. Her physician orders a magnetic resonance imaging of the left foot to further evaluate the heel. X-rays were unremarkable, no fever, no systemic symptoms, and no recent trauma. Which magnetic resonance imaging finding most specifically confirms the diagnosis of calcaneal apophysitis in this patient? Option A, Achilles tendon tear at its calcaneal insertion. Option B, joint mice, meaning loose bodies, within the subtalar joint. Option C, bone marrow edema at the calcaneal apophysis. Option D, cortical break along the posterior calcaneal surface. The correct answer is option C, bone marrow edema at the calcaneal apophysis. On T2, weighted and short tau inversion recovery sequences, magnetic resonance imaging shows high signal intensity within the calcaneal apophysis. Bone marrow edema indicates active inflammation. Absence of cortical disruption rules out stress fracture, and localization to the growth plate confirms apophysitis. Magnetic resonance imaging is most sensitive for detecting early inflammatory changes when X-rays appear normal or show only subtle sclerosis. Indications for magnetic resonance imaging include persistent symptoms beyond 6 weeks, a typical presentation, and the need to rule out stress fracture or osteomyelitis. Magnetic resonance imaging sensitivity approaches 95% for calcaneal apophysitis, compared to 60% for plain radiographs in early disease stages. Case 13. A 12-year-old boy presents with a 3-week history of right heel pain that began gradually after increasing his basketball training intensity. Physical examination reveals localized tenderness over the posterior calcaneus with a positive squeeze test. The child is afebrile with no systemic symptoms. His parents are concerned about possible bone infection. Which laboratory finding would be most helpful in ruling out osteomyelitis as a differential diagnosis? Option A, elevated erythrocyte sedimentation rate and C-reactive protein. Option B, normal inflammatory markers including erythrocyte sedimentation rate, C-reactive protein, and white blood cell count. Option C, markedly elevated white blood cell count with left shift. Option D, positive blood culture with Staphylococcus aureus. The correct answer is option B, normal inflammatory markers including white blood cell count, C-reactive protein, and erythrocyte sedimentation rate. Sever's disease is a traction apophysitis driven by mechanical overuse, not infection or systemic inflammation. Laboratory investigations are not routinely required for diagnosis, as clinical assessment is sufficient. Elevated C-reactive protein, erythrocyte sedimentation rate, or white blood cell count should raise concern for alternative diagnoses such as osteomyelitis, septic arthritis, or juvenile idiopathic arthritis. If any red flags are present, including fever, night pain, erythema, swelling, or failure to improve after 6 to 8 weeks, further workup is required including blood cultures, magnetic resonance imaging, and bone scan. Case 14. A 12-year-old male soccer player presents with a 3-week history of bilateral heel pain that worsens during training sessions and partially resolves with rest overnight. He reports no history of trauma, fever, or systemic symptoms. On examination, there is tenderness over both calcaneal apophyses, a positive bilateral squeeze test, and mild tightness of the gastrocnemius muscles. He is currently limping after practice and is unable to complete full training sessions. What is the most appropriate first-line management for this patient? Option A, immediate surgical intervention on the calcaneal apophysis. Option B, total bed rest and complete cessation of all physical activity. Option C, local corticosteroid injection into the calcaneal apophysis. Option D, activity modification and heel cups with cushioned orthotics. The correct answer is option D, activity modification and heel cups with cushioned orthotics. Activity modification reduces repetitive traction stress on the calcaneal apophysis, which is the root mechanical cause of Sever's disease. Heel cups and heel raises elevate the heel slightly, reducing the pull of the Achilles tendon on the growth plate and absorbing ground impact forces. Together, these two steps address both the biomechanical and loading components of the condition simultaneously. Eccentric exercises and aggressive stretching are introduced only after the acute phase, not as first-line therapy. Most children with Sever's disease respond well to conservative management within 4 to 8 weeks. Surgery is almost never required. Case 15. A 14-year-old male football player has been recovering from Sever's disease for 6 weeks. He completed a period of activity restriction and is now pain-free at rest. His physician notes residual tightness in the calf muscles and mild discomfort with prolonged walking. The goal is to design a rehabilitation program that promotes long-term recovery and prevents recurrence. Examination shows limited ankle dorsiflexion and a positive Silfer-Skjold test indicating gastrocnemius tightness. Which of the following exercise interventions is most beneficial for ensuring long-term recovery and preventing recurrence in this patient? Option A, gastrocnemius soleus stretching program. Option B, heavy weightlifting and resistance training. Option C, complete immobilization with casting. Option D, immediate return to sprinting drills. The correct answer is Option A, gastrocnemius soleus stretching program. Relieving chronic tightness in the gastrocnemius and soleus muscles is the cornerstone of rehabilitation in Sever's disease. These muscles attach via the Achilles tendon directly onto the calcaneal apophysis, which is the inflamed growth plate. Stretching reduces traction on the vulnerable calcaneal apophysis during activity, prevents recurrence by maintaining adequate calf muscle flexibility as bone grows, and is most effective when performed consistently twice daily on both sides. The wall stretch with a straight knee targets the gastrocnemius, while the towel stretch in a seated position targets the soleus and Achilles. Stretching should be painless and held for 30 seconds per set. Aggressive stretching during acute flares may worsen symptoms. Case 16. A 13-year-old active male is brought in for evaluation of bilateral heel pain diagnosed 6 weeks ago as Sever's disease. During the visit, the parents also mentioned that he complains of anterior knee pain after basketball practice, especially when going upstairs. On examination, there is tenderness over the tibial tuberosity bilaterally. Which of the following conditions is most commonly associated with Sever's disease in physically active children? Option A, juvenile idiopathic arthritis. Option B, scoliosis. Option C, Osgood-Schlatter disease. Option D, developmental hip dysplasia. The correct answer is Option C, Osgood-Schlatter disease. Sever's disease and Osgood-Schlatter disease are both traction apophysitis conditions that commonly co-occur in growing athletes. Both result from repetitive stress on immature growth plates during periods of rapid skeletal growth. Up to 30% of children with Sever's disease also develop Osgood-Schlatter disease during their growth spurt years. The mechanical stress from tight muscle tendon units affects multiple apophyses simultaneously, particularly in athletes involved in running and jumping sports. The clinical pearl: screen for multiple overuse injuries when one traction apophysitis is identified. Growth spurts create system-wide vulnerability in active adolescence. Before we conclude, we want to tell you about our exclusive community on Patreon called Pediatric Case Review. All lecture videos are organized by body system, so you can easily find exactly what you need instantly. Every presentation is available as downloadable photo slides, so you can read, review, and practice all questions at your own pace. The community also includes hundreds of case-based multiple-choice questions to sharpen your diagnostic thinking and exam readiness. To get full details on how to join and subscribe, simply comment below on this post, and we will reach out to you directly with everything you need. This brings us to the end of our lecture on Sever's disease, a case-based clinical review. We worked through 16 cases covering diagnosis, bilateral presentation patterns, pain characterization, gait adaptations, physical examination maneuvers, anatomical landmarks, differential diagnosis, pathophysiology, growth spurt dynamics, radiographic interpretation, advanced imaging, laboratory investigations, initial management, rehabilitation, and associated conditions. The 3 key takeaways are: recognize early by always considering calcaneal apophysitis and heel pain in active children aged 8 to 15. Treat conservatively with rest, stretching, heel cups, and activity modification, and reassure families that this is a self-limiting condition with excellent prognosis once the growth plate closes. If you found this lecture helpful, please follow Pediatric Case Review for more evidence-based pediatric lectures. Have a clinical question? Drop it in the comments, and we read every one.